Good morning. Good morning. It is a pleasure to introduce our next speaker. Dr. Donald Dipette is currently the Health Sciences Distinguished Professor at the University of South Carolina and the University of South Carolina School of Medicine in Columbia, South Carolina. He has previously held the positions of Special Assistant to the Provost for Health Affairs, Vice President for Medical Affairs, and Dean of the School of Medicine at the University of South Carolina. Previously, he was Interim Senior Executive Dean and Chairman of Medicine and Professor of Medicine at the Texas A&M Health Sciences Center College of Medicine. Dr. Dipette will be discussing hypertension. Please welcome Dr. Donald Dipette.
Well, thank you, Chris, for that wonderful introduction. And I'm going to try to use this really small gadget and see if it works. It's wonderful to be with family, of course, and it's wonderful to see the meeting in person, take place in person almost entirely now. So I thank everybody who came and everybody that supports, of course, SMA from me and the leadership. I've been asked to talk to you about hypertension this morning, and I didn't put a specific title in the program for a reason, because I wanted it to be broad in terms of the area of hypertension, but I'm really going to focus down to an area that I absolutely am passionate about. And I'm going to give you the reasons why I'm passionate about it. And I hope that we will implement some of the paradigms, if you will, that I'm going to talk to you about today. Okay, see? There we go. Did you do that, or was that me? I did it perfect. What we're really going to talk about, we're not going to talk about hypertension, but of course we are. We're really going to talk about change. How do we change years and years and years of practice? How are we going to change years and years of doing the same thing as physicians and even organizations, for that matter? So one of the leaders, the disciples of organizational change, and I found out by being forced to go to Wharton at the University of Pennsylvania for a physician's executive program while I was in Texas. And it's a gentleman by the name of Cotter. And Cotter, in the 1980s, was looking at the auto industry. And in fact, even I think yesterday or last night, we were talking about another individual named Deming that was also looking at processes. But Cotter was looking at how do organizations change? What's the reticence to change? And what are the barriers to change when change is obvious? He came up with 8 steps. So I'm not going to belabor the last 7, but I am going to talk about the first one. The very first step that Cotter invoked in terms of organizational change was you need a burning platform. You need a why. Why change? And then that why has to be a sense of urgency. And sometimes that takes a while for that sense of urgency to build up until there's a tipping point for change. However, we are at that in terms of hypertension. I'm going to try to outline the sense of urgency and the burning platform for why we need to do things differently starting this morning when we all get back. Number 1, non-communicable diseases globally is the #1 leading cause of morbidity and mortality now in the world. It used to be, of course, infectious disease, public health measures, sanitation, water, not anymore. And now it's coronary disease, it's heart disease, and hypertension is the leading risk factor for non-communicable diseases worldwide. So that's a global sense of urgency. But you say, well, but we're in the United States. Well, we have that same sense of urgency here, as I'm going to show you, and things are getting worse, not better. Globally, the hypertension control rates, as defined by 140/90, is only 20%. Well, what about in the United States? Our control rates, recently reported, I'm going to show you some more data on that, are dismal, and they're only around 45 to 50%, as you can see. In the South, it's even worse. Our jurisdiction, the SMA, 18 states, of course, includes the stroke belt. So the prevalence, the control rates of hypertension in our region is even lower than our national averages. And of course, there's geographic variability within states, but these are more global statewide reporting mechanisms from our DHECs, if you will, our departments of health. And this is on a backdrop that's really a paradox. This is all despite safe, effective, available, affordable pharmacologic agents, as well as a plethora of data with non-pharmacologic lifestyle modifications to address not only blood pressure, but many other blood pressure related disorders, as you know. So that's the paradox. We have such plethora of medications available and they're affordable at the same time when our rates are dismal, our control rates are dismal. So why? What's wrong? The first thing we got to do is we have to start an honest discussion amongst ourselves. That's number one. The why for ourselves. And the honest discussion is we have to stop doing the same thing we've been doing over and over again and expecting different results. That's the definition of insanity. You've heard this many, many times from many, many professors, and you're probably sick and tired of hearing that. But it's the truth. We have to change. We have to start doing things differently. And it starts with an honest discussion amongst ourselves this morning. Well, what's the burning platform for us, not only in our southern states, but nationally? This is the most recent NHANES report, which is our national data, which is nationally distributed across demographics, across socioeconomic platforms that represents the diversity of our country geographically, economically, racially, and ethnically. And up until I would say 2015-ish, we were doing okay. We were content. Every time this report would come available, every 4 to 8 years, our hypertension control rates were slowly and gradually improving, maybe a couple percent per year. And they peaked around 55 to 58%. However, the storm clouds hit, and they hit very, very quickly. In the report in 2017, 2018, for the first time in our history as a country, our hypertension control rates have substantially and statistically significantly declined to a rate of 43 to 48%, as you can see. Well, some of my colleagues said that was just a blip. It was a one survey. Well, the most recent survey just came out. I didn't have time to make a slide of it, but it's the same. They've not improved at all. So it's real. This data prompted our Surgeon General in Washington in the middle. By the way, those results were pre-COVID. I can only imagine what they are, during COVID. But those were pre-COVID, so we cannot use COVID as an excuse. It was 2017, 2018 data set. Well, our Surgeon General saw that and became alarmed. In the middle of COVID, he switched tracks and said, we need a task force to come together. And he issued a Surgeon General's call to action report on hypertension for the first time in 40 years in this country. This is dramatic because it's in the middle of COVID. And they came up with 3 goals in the task force. As you can see, we have to remake hypertension a national priority. When I was a resident and fellow sitting in the seats that many of you are, it was the first time it was a national priority. And then we became more lax and taking things for granted. 2, we have to talk about hypertension everywhere we are, from workplace to clinic to exam room to schools, and in terms of our industries and our social and cultural contexts. But more importantly, this stands out in the report. We have to do something different. And the Surgeon General report said, we have to optimize patient care for hypertension. And the very first strategy is the use of standardized treatment protocols, algorithms, small formularies of safe, affordable, and effective medications. And that's what I'm going to talk to you about. And that's going to require change. So what does all this mean? Even in my lifespan, we've gone from no care for hypertension in the 50s and 60s before there was evidence-based medicine. And even if there was evidence-based medicine, we didn't have safe and effective and affordable pharmacologic agents. However, they became available. The large studies became available showing that lowering blood pressure dramatically improves morbidity and mortality. I'm not telling anything that we don't know this morning. That developed then the step care approach to treating hypertension pharmacologically. Start with a thiazide or thiazide-like diuretic, maximize the dose, start a second one of your choice, maximize the dose, and so forth and so forth. If you did that, it would take you about a year to up-titrate medications, et cetera, and achieve reasonable doses and classes of antihypertensive medications. Well, there was some small improvement. We moved from step care to individualized care. Well, what's the difference? It was really still step care, but now you could choose maybe 1 of 3 or 4 classes of agents as your first agent. But the step care approach was still our standard approach, which is our approach today. So what am I going to advocate for you today? And I'm coming as a part of a team in the United States, a team in the Pan American Health Organization, our region, and the World Health Organization from Geneva. We now need to quickly move to a population-based approach to the treatment of hypertension. What does that mean? That means that we're going to treat most people the same, but it's not all people. So it's a patient-based algorithmic approach for most, but not all. Let's talk about that. Well, why do we want to change this approach? Well, what are some of the barriers? Why aren't we controlling blood pressure right now or hypertension right now? Again, with safe, available, affordable pharmacologic agents. Well, there's patient barriers, as we all know. There's physician provider barriers, and there's health system barriers. I highlight just a few because the ones that are highlighted: adherence, therapeutic inertia, lack of adherence to guidelines, and complex medical regimens and distribution mechanisms and cost are barriers that an affordable, standardized algorithmic approach immediately addresses. And it addresses these barriers the minute you implement it. You don't have to wait a month or 2 months or 3 months. It's the minute you start addressing these barriers. One of the most important barriers now we know is called therapeutic or clinical inertia. We're all aware of that. That's us. We're it. What is the therapeutic inertia is the failure to either start a therapeutic intervention, in this case, a pharmacologic antihypertensive agent, or intensify the dosage when it's absolutely obvious. When every guideline in the books from any country, region, et cetera, says you should, we don't. Let me show you some data of how poorly we were doing. This is interesting data, and this should be a data on human nature, not a data on prescribing antihypertensive medications, because this is human nature. If you look on the far right, individuals that came into the office with a blood pressure greater than 180 systolic, 180. We would all say, boy, that's high. Maybe that should be treated. 55% of those individuals left that office visit with no intensification of dosage or adding a second agent or starting a first one in the first place. That means only 45% of individuals, the therapy was intensified. Well, it gets worse. The lower the systolic blood pressure, this is human nature, the greater the therapeutic or clinical inertia, to the point of between systolic of 150 to 159, 87% of individuals left that office without a dose of intensification or a new medication added, where we would all agree that a blood pressure between 150 and 159 ought to be lowered to whatever goal you just pick a goal, but that's not one of them, right? So that's human nature. Why does that happen? Patients make excuses. I didn't take my meds this morning, Dr. Petty. That ain't going to make any difference if you just skip one dose in the morning. Well, the patient was hurried. Parking's a problem, and it is a terrible problem, especially at our VA, at our medical school. And they're stressed, et cetera. We'll just watch it. No, we're not going to do that anymore. We're going to stop. Well, I've had colleagues, that's national data. I've had colleagues in South Carolina tell me that's not in South Carolina. That doesn't happen with us. We're not doing that. Well, this is our data from South Carolina showing the exact same thing. In yellow is individuals that left the practice, that office, with clinical therapeutic inertia. In other words, medicines were not intensified or added or started. The red shows those that did. Look at the difference between the two. Systolic blood pressure goes from 139 to 125 if you intensify the dose or start another treatment. Diastolics goes down to 73. Your percent control rate goes from 45%, now our national average, but all you had to do was intensify or add a medication, and it goes to almost 80%. But look at the top. Look at the very, very bottom, and this is the percentage of visits where therapeutic inertia occurred. And this is in South Carolina, North Carolina, and Georgia, right smack in the middle of our states. How about this? 87% of individuals left without intensification, actually mirroring the national study I just showed you. So it's on us as well. So how are we going to change this? We're going to change this by doing things in a standardized population approach, not losing sight of the fact that always we treat individuals as individual patients, people, and family, of course. But that's going to be the exception, not the rule. So what are some of the key advantages of using a population-based public health? And this is a primary care approach, because hypertension is a primary care treated disorder predominantly. Number one, it's a critical strategy to increase hypertension control rates, as I'm going to show you. Number two, it addresses clinical and therapeutic inertia because it tells you you must do this. If you have an algorithm or you have a threshold, it's not I may or I can or I should. No, it's you must. It should be simple, straightforward, and standardized, as I'm going to show you. I'll give you some examples. And it can be adopted anywhere. It can be adopted in individual practice, or a group, or a system, a state, or even a country, as I will show you. It's scalable and transportable because it's the same approach no matter where you start it. So what are some of the guiding principles? Well, it has to be primary care based. We love our specialty colleagues and they should be at the seat of the table in the discussions, but at the end of the day, it's a primary care based initiative. The algorithm should address the patient rule, not the exception. We can all say, well, those are somebody else's patients. All my patients are individual, they're all different. No, they're not. 80 to 85% of our patient population is all the same. And I'll show you that. The algorithm should have as few titration steps as possible, and it should have no branch points. I think you've all seen algorithms where there's arrows everywhere. Well, what do we do with that algorithm? We either put it on a shelf or throw it away because it's indiscernible. We're too busy and there's too many of them. So it has to be straightforward and simple. And these are the two caveats that I want to leave you with, but we're going to talk about it a lot more. You need to start with 2 medications, not 1 anymore. Those days are over. We need to start 2 complementary classes of antihypertensive pharmacologic agents at once upon the initial diagnosis at half maximal doses of each of those agents. If you start with half maximal doses, you only need 1 titration step to get to maximal doses of 2 agents, 1 month. And of course, if you can do it in a fixed dose combination, that's better, but that should not stop us from using 2 medications and 2 single pills if needed. So what are the advantages of initial pharmacologic therapy in combination from complementary classes? When we use complementary classes together, and we're going to show some examples of those classes, we do all these good things. First of all, 80 to 90% of our hypertensive patients right now, especially with guidelines that are decreasing the target blood pressure, are going to require 2 or more antihypertensive agents anyway. So why not start with 2? If almost all of them are going to require 2, and why wait? Number 2, if we use complementary classes, they're additive in terms of their blood pressure reduction or even synergistic in some individuals. It allows lower doses of each of those 2 medicines because you're not maximizing either of them unless needed. So side effect profiles are better. And the blood pressure reduction is greater when combination agents are used than the single maximal dose of either of those agents. That data is clear. So why are we doing what we're doing? It simplifies the regimen, better adherence, and better persistence to care. It reduces clinical inertia. This is, I think, the most important one. If we're taking about the population-based approach, our algorithms, our treatment should work in everybody. When you use combination medications from complementary classes, you equalize the blood pressure across classes. I don't care where you are. Around the world, you could be in Vietnam. You could be in Brazil, you could be in Colombia, South Carolina. Race, ethnicity, sex, etc. The blood pressures are lowered equally, and I'm going to show you that data. It completely takes away the disparity of blood pressure reduction across diverse groups. And there's economic benefits down the road. Initially, the pharmacologic costs might be small, but greater. However, the economic benefits of reduced visits and, of course, improved outcomes is obvious. The CDC has published huge amount of data showing the cost effectiveness, even in low-income countries around the world. So I've talked about mitigation of side effects when you use complementary classes, and here's some examples. When you use a renin-angiotensin aldosterone system inhibitors, such as an ACE inhibitor, or preferably, as I'm going to show you, an ARB, with a calcium channel blocker. The RAS inhibition blocks the sympathetic activation of the calcium channel blocker. In this case, it's going to be amlodipine, because that's the only one we're recommending right now. That's simple. It also blunts the pedal edema, almost 80%. And it decreases proteinuria if your individual has proteinuria, of course, because we know RAS inhibition decreases proteinuria in those that have it. So you automatically mitigate the side effects of the calcium channel blocker, the most common ones that lead to poor adherence. Well, what about the combination with a thiazide or a thiazide-like diuretic? When you use a RAS inhibitor with a thiazide or thiazide-like diuretic, you blunt the sympathetic activation of the thiazide diuretic. You also improve the hypokalemia, hyperglycemia, and hypercholesterolemia of the diuretic. And similarly, the diuretic inhibits and mitigates the hyperkalemia of RAS inhibition. So let's use them together as we're always doing. We're just doing them too late. Let's start with either of these choices. So what would be the ideal characteristics of two classes if we were going to choose two? And believe it or not, some of my colleagues are already well beyond me. They're saying we should start 3 medications at once or 4 medications at once. I'm conservative. I'm just saying 2 right now for today. But you're going to be hearing 3 and 4 in the not too distant future. Well, they should be efficacious, of course. They should have synergistic or additive blood pressure reduction in all populations. They should be supported, of course, by evidence and mitigate side effects that we've talked about. They should be widely available and affordable if we had our wish list. And of course, they should be safe and efficacious across populations, daily dosing for adherence. And even if they're scored, it's even better yet, because you can more easily split the pill and save money. So these are the 3 classes that most now, if not all, hypertension guidelines now recommend. You choose from the diuretics, the calcium channel antagonists, and this would be amlodipine, a 1,4 long-acting 1,4 dihydropyridine, or an ACE inhibitor, or preferably an ARB, as I will show you. So if you're going to choose 2 medications, there's only a few permutation and combinations up here. It's not rocket science. It's pretty straightforward, and we're going to go through these combinations. I always put this here because I always get asked, what about beta blockers? Beta blockers are not a first-line antihypertensive agent. They could be 5th, 6th, or 7th, or treated or used for other mitigating factors, but not for the treatment of hypertension because they lower blood pressure, but they don't lower stroke. And that's been a puzzle to all of us, if you will. But nevertheless, that's why you don't see beta blockers out here. They're gone in any major hypertension guideline. So how are we going to select? I was asked by the leadership from the World Health Organization to convene a group several years ago, right smack in the middle of COVID, as you can see, because it had that degree of importance, to talk about a blueprint for moving forward globally for using 2 medications at once, and how are you going to choose the classes, and how are you going to choose the individual agents. And here's what we came up with. And this was a global group of individuals. I would say about 80% of them were subspecialists, 20% were primary care. Number 1, first, select the classes you're going to choose, the 2 classes out of those 3, those permutation and combinations. Once you select the class, select the agent. And then once you select the agent, it's got to be safe, available, and affordable. And that's key. Even if it's not the most optimal or preferable agent, you have to select the one that you have. And here's what we came up with when we looked at the literature and we did systematic reviews. This was published in the Journal of Clinical Hypertension in 2019. And as you can see, we chose classes such as RAS inhibition and calcium channel blockade as the first class and the first combination. Why? Because the evidence more strongly supports this combination, I'll bet it's weak. We chose the ARB, an angiotensin receptor blocker, over an ACE. Because why use an ACE inhibitor if you can use an ARB and not have to deal with angioedema, which is fatal, and or cough, which is a nuisance, especially if it's a global approach, because we know cough changes with demographics. If you're doing it globally, cough could be 40% in Hong Kong and 15% in suburban Columbia, South Carolina. But let's just have 0. if we can have an ARB, if it's available and affordable. Then if not, an ACE inhibitor, calcium channel blocker would be our next choice. An ARB plus a thiazide or thiazide-like diuretic. And lastly, an ACE inhibitor and diuretic. As you can see, CCB is over diuretic and ARB is over ACE inhibitor, if possible. These are all acceptable combinations. We chose not to recommend the calcium channel blocker diuretic combination just because there's no evidence, there was lack of data. However, in individuals that can't use a RAS inhibitor, especially if you're childbearing and or you're childbearing potential and you're actively becoming pregnant, you're not going to use a RAS inhibitor. So this combination would be your choice. And now what about the individual agents within the classes? Well, it would be those ideal characteristics. You can see we just gave some examples of the ARB first. Any long-acting ARB will do as preferred. But as you're going to see, there's short-acting ARB, losartan, that many of us are using, which is absolutely okay. The calcium channel blockers always amlodipine, at least today, because it's worldwide, safe, effective, and globally available and cheap. The ACE inhibitors, again, same rule, long-acting ACE inhibitor plus amlodipine. It's the same rule, ARBs over thiazide over ACE with the thiazide-like diuretic, but we strongly recommend chlorthalidone because if it's longer half-life, we're all using hydrochlorothiazide, I get it. And chlorthalidone is a little more expensive and a little less available. But the more we use it, the more available it's going to be and the more dosage that the pharmaceutical industry will make for us. I just came back from India. They have umpteen doses of chlorthalidone in India. I wanted to move my practice tomorrow because they had such a wide array of dosage recommendations. We don't. On the other hand, that's going to change, I guarantee it. Or you can still use hydrochlorothiazide. And this is an approach that we're talking about worldwide. In other words, develop your protocol today. As you're going home, think about your protocol for tomorrow. And put your current protocol in place. It may not be optimal, it may not be the preferred protocol, but do today's work today, plan tomorrow's work tomorrow. While you're also in parallel, looking at how can you achieve an acceptable protocol or even go right to a preferred protocol, and I'll show you some examples. And I'll show you an example in Columbia, South Carolina, where we're still in the current protocol. And there's no shame in that. So this is one such protocol. This would be a current protocol that you might be able to put in place today. It starts with 2 medications. It's got that caveat. In combination upon the initial diagnosis. This is the minute the blood pressure is 140 over 90 or greater, or whatever other target threshold you want to use. Losartan, an ARB, half maximal dose, 50 milligrams. And amlodipine, half maximal dose, 5. First time the diagnosis is confirmed. 50 of losartan, 5 of amlodipine. They come back 1 month later, they're still not controlled. By controlled, mean they're 140 over 90 or greater. You double the dose of both to 110. They come back 1 month later, they're still not controlled. You add, in this case, it's a hydrochlorothiazide, half maximal dose, 25 milligrams. They're still not controlled. You double the dose of the hydrochlorothiazide. So within 3 months, you've got 3 medications at maximal doses. That'll control 85 to 90% of your individuals in your practice, period. There's going to always be exceptions, and that's time for individual care, more obvious discussion by adherence, et cetera, or prefer, or add a 4th agent such as spironolactone or the agent of your choice. But this is where we leave it for now. That's a current protocol, but it's not preferable. We could do better. And here would be one that's absolutely preferred. Instead of the losartan, you can see telmisartan. It's just an example. A long-acting ARB at half maximal dose of 40 milligrams. Everything else is the same until you get down to the diuretic. And now it's a thiazide-like diuretic, chlorthalidone at 12.5 milligrams, which is half maximal dose, and you would double it to 25. So the only 2 changes between a preferred protocol is a long-acting ARB and losartan, and a longer-acting thiazide-like diuretic, chlorthalidone. But it's difficult to get to this protocol. This shows it works. This is Kaiser Permanente in California. Kaiser Permanente, of course, is one of the larger health systems in our country. They noticed that their hypertension control rates were dismal in the early 2000s. And they said, we have to do something different. They were way ahead of the curve. And they started a similar protocol with 2 medications upon initial diagnosis. In this case, it was an ACE inhibitor, lisinopril, and a thiazide diuretic, hydrochlorothiazide, at once. And then they doubled it every month with the exact same paradigm, added the calcium channel blocker third. Same 3 medications, same 3 classes, same 3 rules, just a little bit of shifting of the deck chairs. Well, what happened? Okay, I don't know what happened. Here's what happened. Their data is shown in blue. They started with a hypertension control rate of 44%. They said that's dismal and unacceptable. The national average even then was 55%. California wasn't even measuring their control rates at that time. But you can see how quickly, in 2004, they started the protocol. Within a year, it went up to 78%, and now it's 90% control rates by using the algorithm approach, a population-based approach, if you will. And the outcomes are equally impressive. Everything has declined. It's not cause and effect because they're independent events, but their strokes, their heart attacks, their MIs have all dramatically reduced. Now, they can be multifactorial. They have a statin program, for instance, et cetera. On the other hand, most of this is from hypertension control. And it's been sustained over the last 10 years. There's been no recidivism of the control rates. But this is the most important data. And I dragged this out of my colleagues at Kaiser Permanente, who are world leaders now in this area. And I said, what are your demographics? And here's their data that they put forth. It didn't matter who or what you were. When you use the combination therapy as initial management in a standardized protocol, you can see that the hypertension, the blood pressure control rates are all the same. Whether you're other, whether you're non-Hispanic white or European white, for instance, whether you're Hispanic, Black, or Asian Pacific, they're all the same because you're using complementary classes. That's called population medicine. You can use this rationale and this treatment algorithm and go around the entire world and you will lower the control rates the same in everyone. So what are some of the results? Our Hearts program, which started in the Pan American distribution, Latin American and the Caribbean, I was blessed to be one of the leaders at the very, very initiation of the program in 2013. We started in 4 countries, Barbados, Chile, Colombia, and Cuba, for instance. And notice they're out there, they use a fixed dose combination. They accepted the general guiding principles, but they all use different combinations. That didn't matter. What mattered was they started 2 complementary agents in the first place, from lisinopril hydrochlorothiazide in Barbados to enalapril and hydrochlorothiazide in Cuba. That was not an issue. We wanted them to do better, and they've all changed their protocols now over time. We're now up to 28 countries in Latin America and the Caribbean employing and initiating Hearts with this protocol. And there's other components of Hearts too, but this is the core. It's the heart of Hearts is what we say. And here's Barbados, the control rates within 18 months. And it was actually even quicker than this, except they used 18 months as their cutoff. They started with a baseline hypertension control rate of 51%. And within 18 months, they're at 66%. And they're now even greater than that. Everyone instantly demonstrates improved hypertension control rates. I can show you the same data from Santiago, Chile, from Matanzas, Cuba, et cetera. There's a rapid augmentation of hypertension control rates immediately. So what are we doing locally? Am I just an academician talking to you about, what if kind of things? The answer is no. I practice in an inner city, low socioeconomic clinic. Buckley's practiced with me in this clinic. It's our internal medicine clinic and our data in Colombia. Again, it's inner city. You can see the age. It's predominantly older. That would be expected. It's heavily female versus male. We have to do something about that to get our guys in the clinic, but nevertheless. And notice it's heavily African-American or Afro-descent. It's 80% Afro-descent. I won't go through the demographics, but everybody has low income as well. And it's a relatively free clinic with moderation of some co-pays, really, really minimal. But we noticed that our control rates were dismal in this population. So what did we do? This was the protocol we initiated. It wasn't the first one. Our first one started with lisinopril and calcium channel blocker, but we were able to continue to plan, and we now moved to losartan, 50 milligrams and amlodipine 5. That previous protocol I just showed you, that's current. It's not preferred. I wish we could do better, but right now that's what we can do. And you do what you can do today, plan what you can do tomorrow. And the exact same thing, half maximal doses. Within 1 month, if they're not controlled, double the doses. If they're not controlled, add a third agent. In this case, it's hydrochlorothiazide. We wish we could use morphalidone, and we're trying to plan that. And then double that, and we actually have a protocol that extends to spironolactone too in our primary care clinic. So we're walking the walk and talking the talk. And I was also very honored to be part of the WHO, World Health Organization Guideline Committee, that just reported their guidelines this year. I was the co-chair of the writing committee. And for the first time in WHO history, they about actually now solidly recommending, the word suggests, but that means the evidence is positive to starting this. One of their single recommendations is to start with combination therapy from one of those 3 classes that are recommended in the guideline upon the initial diagnosis of hypertension. Don't wait. In fact, we even go so far as don't even do lab tests if they interfere with starting pharmacologic therapy. Of course, get lab tests if you can, etc. And they also recommend in the WHO guidelines how often you need to assess the patient. This is another barrier. We are not seeing our patients often enough. The every 3 months or every 6 months, which turns into 6 months in 1 year, is unacceptable. 1 month, if not sooner. Kaiser Permanente, it's 2 weeks. So if they see patients in 2 weeks, they will initiate and up-titrate medications, but more likely their data shows they'll see them in a month. But anyway, we at least could agree on 1 month for while you're titrating and adding medications. Once you're controlled, every 3 to 6 months, 3 to 6 months in high-risk patients, 6 months in low-risk patients. But all of the patients that we see are high risk. So let's finish. We've now put this together. This is the HEARTS program, of course, in an overall package. And the package includes measuring blood pressure accurately with validated devices, to acknowledging cardiovascular risk, because some of our guidelines, the thresholds and the treatment targets differ upon risk, cardiovascular risk. And then, of course, you can see, but in the centerpiece is the algorithm. And here's the telmisartan and amlodipine algorithm, which again, is just an example. Any other long-acting ARB would do, would be absolutely preferred. And again, only 4 steps to get maximal doses of the 3 classes. So let's end. What are some of the musts? Not the shoulds, not the maybes. What are some of the musts? We must include stakeholders in our individual practices, our health systems, if you will, or even geographically our states and country. But the key leadership has to be primary care based. We've learned our lessons with the HEARTS program. Number 2, it has to be simple. Notice how simple those algorithms were. There was no branch points. There was only 4 steps on all of them to get 3 maximal doses of 3 medications. They have to be aimed at the hypertension individual cared for in the primary care setting, not the patient exception. There's always going to be patient exceptions, and that's the beauty of medicine. But that's what individualized care is for, and that's what our subspecialty colleagues are for to help us. The algorithm, the protocol will address clinical inertia. Patient care intervals are key, and even if better, a team-based approach where non-physicians could follow the algorithm and titrate medications. Kaiser Permanente allows non-physicians to titrate medications according to the protocol. Of course, the primary care physician is always in the loop and aware. Use 2 complementary classes, as we've already shown, and use fixed dose combinations where possible because there's greater adherence to fixed dose combinations versus 2 single pills, but don't let that stop you from using 2 single pills. Now we'll conclude. So, how are we going to transition? How are we going to do this? We've developed the burning platform. Now how? Well, we're going to use standardized, simplified approaches to hypertension detection and treatment. We're going to develop small, specific medication formularies. Notice with with an algorithm such as this, you only need probably about 4 or at most 6 antihypertensive medications. Forget all the others. That sure simplifies things. Implement a straightforward pharmacologic treatment protocol using combination therapy, preferably fixed dose combinations, starting, and this is again a key guiding principle, half maximal doses of each. And employ a stepwise approach to your protocol development. Start with a current one that you can start today. Plan for tomorrow. If it's not a preferable protocol, that's absolutely okay. That's what we're doing in our clinics in internal medicine at USC. In Columbia, and our family medicine colleagues have now invited me to the table, and family medicine has accepted this approach as well, and they're developing their algorithm now. I can't wait to see. Thank you very, very much for having me this morning.
Thank you, Dr. Dipette, for a wonderful presentation. Any questions from you?
All right, I jotted these down as you're going.
Okay, go ahead.
So my first question, all the slides said 140 over 90.
Yes.
I've seen some less than 130 over less than 80 guidelines out there. Any
Yes.
thoughts on where we should be targeting?
Absolutely. I didn't want to make this a guideline talk. I wanted to make this a, how are you going to start treating and how are you going to increase control? Yes, even the WHO, the latest WHO guidelines say in low risk, the general population of low risk hypertension, the WHO guidelines still use 140 over 90 in that population as a treatment threshold to initiate antihypertensive medication. And that's what we've used in the heart's program, if you will. However, even in those recommendations, if you've got known cardiovascular disease, the threshold is 130 over 90. If your other 3 groups, if you're high cardiovascular risk by a calculator, whatever risk calculator you're comfortable using, it's 130 over 80. That'd be greater than 10% cardiovascular risk. If you have diabetes or chronic kidney disease, it's 130 over 80.
Another one, when you're talking about worldwide and low-income guidelines, did it come up at all? And I know from personal experience, I see this a lot. When I go from hydrochlorothiazide to chlorthalidone, my hypokalemia rates go way up.
Okay.
Did lab availability weigh in at all in the guidelines?
Yeah, one of our actual recommendations is we were asked to deliberate on whether you need labs to initiate antihypertensive medications, including chlorthalidone, for instance. And this is key. This is important worldwide where labs aren't readily available. And the answer is you do not.
What about to continue it?
Well, if you can always get labs before, that's better. And if you can get labs in timely fashion, even after you start medications, of course, get labs and follow the labs. My question to you, though, on the chlorthalidone and hypokalemia is, are you using it in combination with a renin-angiotensin system inhibitor? Because that would mitigate the hypokalemia. And we're not seeing appreciable hypokalemia with those doses of chlorthalidone of 12.5 to 25. Now, we are seeing some hyponatremia. That's for sure. That's different. But again, that can even be mitigated.
Thanks.
Again, excellent presentation. I was very pleased in my practice. I normally give my patients 3 things. One, samples of a Darby chlor to take in the morning, a blood pressure sheet that has 3 things, systolic, diastolic, and pulse rate, and then amlodipine to add at night to sort of minimize some of the swelling. If their systolic pressure is over 140, they take 5. If it's over 160, they can take 2 of them. And it seems to work very well. I see them back in 2 weeks. They bring their machine in so we can make sure that it's not garbage in, garbage out. A lot of time, education and empower them to take their own blood pressure twice a day, morning and evening, bring that data point in. And again, they don't get to see me if the machines correlate and they're under good control. But again, I have great success with exactly what you're doing, just using a little longer acting, ARB.
But you're doing exactly what the algorithm says.
I was surprised.
You're using a long-acting ARB,
And my
and
patients
you're
are,
using a calcium channel blocker, and then you're using a thiazide or thiazide-like diuretic.
and I allow them make the choice how much they take in the evening time, empowering them.
That's absolutely correct. And that's even a difficult question at a systems level, and that gets to team-based care. You're doing it at a practice level and at a patient level. We're still even trying to get health systems to allow non-physicians in a team-based approach to follow the algorithm and up-titrate medications. What was interesting to me when I traveled so often is individuals with HIV, AIDS, or Hep C worldwide, they've been doing this for years. They don't have physicians to titrate antivirals. They allow an algorithm to dictate, and any health care individual at that clinic in rural Africa, for instance, can up-titrate, start and up-titrate medications.
Empowering them so they can take.
Absolutely.
Given generalized, I guess, resistance to change, is there any concern that physicians will be waiting until later and later and more elevated blood pressures to then start the stool therapy?
To start pharmacologic therapy,
Yeah.
Buckley? No. Age, notice that age doesn't matter. Age is now out of the question because we know of all ages start antihypertensive medications at the same threshold that you decide on according to which guidelines you want to listen to. Of course, the earlier we start antihypertensive medications in the patient's natural history, the better.
Are they resistant to this? Would
Yeah.
they start at 150 over 100 as opposed to 140 over 90? just because
That
of the rules?
resistance is going away because of more and more clinical-based evidence that we should start at lower and lower thresholds. We are still meeting some physician resistance, however, in starting 2 medications at once. And that is largely geographic, and it's largely like specialty versus primary care based. I won't say politics, but mild tensions. So we are seeing some resistance regarding that concept. However, that glass ceiling is breaking as all these countries now are reporting their results.
Yeah, Dr. Green.
Donna,
Is there any evidence on timing, like morning versus
That's
night?
I will- the check is in the mail. Donna, because I get that question all the time, and that is because there has been previous studies from one center in Spain that shows that their blood pressures were lower and their outcomes were better if you dose the medications at night as opposed to in the morning.
Both of them?
All of them, they did all of them. However, that's wrong. It was flawed. All of their data was flawed. There was just this week a report from Europe called the Time Study, which looked at outcomes, divided patients into getting all their medicines in the morning, and it's half of the group getting all their medicines at night, and there was no difference in outcomes. So now we can dispel that myth. On the other hand, if patients are more comfortable splitting them up or taking them all at night or during the day, that's a patient and physician preference. But there's no science, there's no evidence base now that says we should be doing that. They should be once a day, and anytime once a day you can take the medications to lead to adherence, the better on that individual patient.
Dr. Dipette,
Yes.
thank you so much.
Hi, Anna.
Great day. And I am so motivated when I get back tomorrow to make some changes within my practice. As you know, I work in the community health center and have many barriers. One thing that I wanted to make mention, a comment and a question, as you talk about increasing the number of visits to get patients to those levels, there's a couple barriers that we need to realize. Number one is that patients really don't want to, and we have telehealth and things like that to address these issues, but then patients don't have means to check their blood pressures at home. And, HHS is now, giving out grants so that we are able to get blood pressure machines to our patients, but that's not totally across the board. So that still creates a barrier. But for patients to be able to come in to see their physician, provider, monthly, that includes a copay, that includes transportation, that includes, there's so many
There are.
issues. How do you, and one thing, as you talk about primary care, we've been talking on the advocacy side for many years about making sure that there is no copay attached to those primary care visits. As we talk about inflation, so
Sure.
how do you see us, and where do we as physicians need to go as far as advocacy to alleviate these barriers that continue to exist?
Well, Ada, we're key. I mean, we're central. We're it, right? I mean, if we don't do it, who else is going to do it? I mean, there's other organizations that are partnering with us. All those questions are absolutely real. This doesn't eliminate all the barriers, this approach, but this will eliminate a significant number of barriers. One thing that other health systems are doing, Ada, is they're not charging copays for return visits for hypertension because you're not seeing the physician. This could be done by the medical team in a team-based approach. The patient can come in for a blood pressure check, and then that team or whomever can then up titrate or add medications according to the physician-approved algorithm. And thus a copay then is not rendered or required. That's one thing. Transportation is always a problem. It's really a problem globally. We think we have it bad. Go to some of the countries that I visited recently, Ada. What they do is they send community health workers to the patient. They've given up on getting the patient to them. So we're going to go where the patient is. I don't know if we're ready for that, in our country, in Colombia, for instance, or our states, but that's how some of the low-income countries are addressing transportation issues. Of course, now portability of smartphone blood pressure medicines that rapidly connect to a central source. That's another approach. Kansas is doing that approach in a very, very major way in the rural setting. So there's other programs ongoing to address these barriers. But again, we can start somewhere. And if we start just this much, I guarantee you we'll be doing good. While we're also planning the future. Then I'll add two other things I didn't add. You're going to hear two other parameters in the not too distant future. We're talking about hypertension control rates, but that's in your population. There's two other very important parameters you're going to be hearing, and that's time to target. How quickly do you get to that hypertension control? The more quickly you get to that hypertension control, the outcomes plummet, especially stroke. So you're going to hear time to target as another parameter. And the more recent one is time within therapeutic range. And then it's how often over the course of years is your patient controlled, whatever threshold you want to use for hypertension control. So there's going to be three. Right now, we're still centering on control rates in your population, but time to target and time within therapeutic window is going to be two other parameters that are being shown to be very important to outcomes.
All right.
Well, again, thank you very, very much, Chris, for the introduction.